A very good morning and good evening, and a very warm welcome to all present here today for this necessary and important session on the COVID-19 vaccine, everything you would want to know. I am Rotarian Jahangir Adranwala from the Rotary Club of Mumbai Mahim, and I would request now President Usha to give her welcome address. Over to you, Usha.
Thank you, Jahangir. This is Usha, welcoming each one of you to this very, very important and very apt session. It is something which everybody wants to know a little bit more to what we keep reading about. So this is a session which we have planned right at the right time and the right schedule. So we thank Dr. Lukena for actually accepting our invite to give this session to this group. So we welcome her. We welcome Dr. Bal Inamdar for having graciously accepted our request to be the chief guest to this session. And I welcome all of you who have taken this time to join us today on this weekend. We are usually live in this world of choices. Everything that we do, we have been lucky to have choices. But this is one COVID situation where we don't have choices. Whatever we have told, now that there are vaccines, what vaccine is given, we have to use it. There are a lot of debate and discussions about the combination of vaccines, what to give, when to give, whom all to give. There is a lot of discussions, but one thing that we are all sure of is that we have to take this vaccine. So in a way, the opportunity of a choice is no longer in our hands. So knowing this, it's very, very important for us to understand the basis or the background of the COVID-19, the vaccines, how it is going to affect us, and then take it ahead. So I welcome all of you to this session and to make this a very interesting session for all of us who are not so well in the medical field, who just read and try and understand what it is. So here it is. Go ahead, Jahangir, take it up.
Thank you, Rotarian Usha. Now I would like to request Rotarian Prakash Samudra to introduce the chief guest, which is past District Governor Dr. Bal Inamdar.
Thank you, Jahangir, and let me also put on record presence of our past District Governor Dr. Madhukar Bide. Mr. Bide, welcome, please, Rotarian Bide. So I got a pleasant task of introducing Dr. Bal Inamdar, and it is very difficult to introduce him in matter of half a minute, which is given to me. He was very particular. I should not spend too much time, but I know him for a long time, and I know his biotech can take at least half an hour. I just want to give a glimpse of what Dr. Bal Inamdar is. Number one, he is a very accomplished and very professionally known gynecologist. He is in Rotary District 3141 now, and it was District 3140 when he was the past district governor in the year 1213. His accomplishment in the Rotary are enormous. We can talk for about half an hour, but noteworthy are, he is a pioneer for the senior officer training programs, pediatric heart surgeries, which is one of the important projects of our district. Bal is the initiator for that, and by now about 2,000 operations have been done all over Mumbai and other cities, in major cities by our district. Water Raila, services, maternal mortality, then expert on global grant, TRF, training leader at San Diego with about 530 district governor. He did training for them, and presently Rotary Foundation is the regional organizer cadre for South Asia and controlling 8 countries. Dr. Bal Inamdar, this is a very small glimpse. I won't do justice in half a minute. Welcome again for this important program. Jahangir, may I request Bal to give inaugural address?
Thank you, Prakash. I think I can go ahead, right?
Yes,
Jahangir?
Yes.
Since Jahangir is the main person here, I need to take his permission.
Sure, absolutely. Go ahead, sir.
Thank you. Thank you. First of all, let me say that it's a pleasure always to come to Rotary Club of Mumbai Mahim. For years together, all of you have been my friends, and I have interacted with many of you. Many of you are my close friends, and always coming to Mahim is like a homecoming for me, because I have seen a lot of changes which have taken place in Mahim. over a period of time. And I'm so very proud of your club. Whether it is the question of growing, or whether it's a question of having your fast global brands, or a question of having your forays into different areas of service. And it's really fabulous to have and to be with Mumbai Mind, and it's a pleasure for me. Today's topic is a very peculiar topic. Peculiar because it is something, all viruses are always troublesome viruses. And most of the viruses we don't have any treatment. Most of them. Very few viruses we have treatment. And we try to see that if we don't have treatment, then we have at least the vaccine, which works. Now, vaccine has its own history. And vaccine has its own way of putting itself into the pedestal of, into the armamentarium of doctors. It takes a lot of time. A good vaccine normally takes anywhere between 2 years to 6 years, maybe more sometimes, to know the nuances of vaccine. But this particular vaccine, because the threat to the mankind, this particular vaccine has bypassed so many obstacles and bypassed so many necessary steps that we have to have this vaccine. And as Usha very rightly said, now there is no question of not having it. In medical world, we feel that whether we should have or vaccine, there is no question. But whether I should have vaccine tomorrow or after 2 months, that is the question. So that delay, whether I will take on myself the chances of complications, or I will see somebody else having complications and then think, because this vaccine is not yet fully tested the way it should be as a normal WHO parameters are concerned, and that's the question. But at the end of the day, all of us as humans, we are optimists. We are not pessimists. And when we are not pessimistic, we know that. Remember, no pessimist has ever discovered new things. No pessimist has ever discovered uncharted land or uncharted waters. If Columbus, he would have been a pessimist. He would never have invented America. So my point is that at a point of time, this particular very historic point of time, we are at a juncture where A, we are running away from the virus, which is going to kill us, and B, we are going to embrace a vaccine shortly, about which we have no idea. And that, to my mind, is the uncertainty it is all about. Today, I'm going to really listen very carefully to Dr. Mukherjee. She is an expert, I have been told, and I may ask you questions later on. However, it's important for me as a practicing doctor, and I've been practicing throughout this pandemic. Throughout this pandemic, I have been practicing my profession. Trying to save myself is the first issue, first point for me, and then treating my patients. But at the same time, so far I have been successful. I do not know what is going to happen after 2 months or 3 months or 4 months or 6 months. But meanwhile, if I get a vaccine, I can protect myself and help so many patients. So my viewpoint is very clear. Even though it is an uncharted water, even though it is something which is not known, even though I have no idea whether vaccine is going to kill me or maim me or vaccine is going to help me, still I am going to go to the vaccine because I know corona is going to trouble me, if not now, then tomorrow. And same is the case with all of us. It's always better to go at such things optimistically rather than pessimistically. And I am here to take that vaccine as and when it comes, in whatever format and in whatever dosages that WHO will ask me to take, I will take it, not bothering about the complications that will set in. Let it be me who give life to the populace. If there are complications, fair enough, nothing wrong in that. But I'm going to be very, very optimistic. I'm going to take this vaccine. So thank you so much for inviting me. I know it's a very short time and all of us are waiting, including me. I'm waiting to listen to Lukena. Let's get on with it. Thank you so much, Prakash and Usha, for inviting.
Thank you, Bal. Thank you very much.
Thank you, Dr. Balinamdar. May I now request Rotarian Asawari to introduce the speaker and to go ahead and read out the citation, please.
Yes. Hello, everybody. The COVID-19 pandemic has affected the whole world in ways mankind has never been before. It's far from over, and its economic consequences will take quite some time before near normalcy returns. But the light at the end of the tunnel is the promise of the COVID vaccine. We all earnestly look forward to receive our dose and get the magical protection we all are longing for. In this current context, we are fortunate to have in our midst Dr. Lukena Karkhanis, MD from USA, who is an expert in the field of allergy and immunology. She will unravel the mysteries of the much awaited COVID-19 vaccine. Let me start with a short introduction of this highly talented personality. Dr. Lukena Karkhanis, MD, diplomat, American Board of Allergy and Immunology, joined Allergy SA, Texas in 2014. She is board certified in internal medicine and allergy and immunology. She received her medical degree with honors from St. Louis Medical College and KM Hospital in Mumbai, India. She was engaged in research activities at the University of Pittsburgh, after which she completed her internship and residency in internal medicine at St. Luke's Roosevelt Hospital Center and Columbia University in New York, and her fellowship in allergy and immunology from Washington University School of Medicine and Burnish Jewish Hospital in St. Louis, Missouri. A brilliant student right from her school days, she has excelled in her academic and professional pursuits all along. A much sought after speaker at national allergy meetings, she has presented and published multiple reports and papers of international repute. She is also an active member of the following organizations: American Academy of Allergy, Asthma and Immunology, American College of Allergy, Asthma and Immunology, Texas Medical Association, Texas Allergy, Asthma and Immunology Society, San Antonio Allergy, Asthma and Immunology. Dr. Lukena also serves as a sub-investigator on several studies at the Allergy and Asthma Research Center, which keeps her abreast of the latest development in a field. Her prominent achievement, amongst other, is the development of a breakthrough medication to treat one of the most common food allergies, that is peanut allergy. This has been approved by FDA. As an allergist immunologist, she treats disorders of the immune system, including food, insect, respiratory allergy, asthma, eczema, and other immune deficiencies like HIV, AIDS for pediatric and adult patients. She has given interview for Fox Daytime and in other forums wherein she presents to the common layman in a lucid manner practical solutions to this complex malady. For leisure and recreation, she enjoys art, literature, culinary experimentation, and spending time with her family. Dr. Lukena is indirectly a part of the Rotary family. Her mother, Rotarian Julina Karkhanis, is a dynamic member of our Rotary Club of Mumbai Mahim. Dr. Lukena Karkhanis, through her content-filled and hope-soaked address, has given us a rare insight into practical solutions to protect mankind from the ravages of COVID-19. By creating this positive awareness, she is doing exemplary service to our countrymen. We at Rotary Club of Mumbai Mahim are really privileged to have Dr. Lukena Karkhanis amongst us and take great pride to honor Dr. Lukena Karkhanis by handing over this citation at our weekly meeting held on 9th January 2021, conducted through Zoom Meet, signed by Rotarian Usha Yagnasesan, President, Rotary Club of Mumbai Mahim, Rotary District 3141, January 9, 2021. Thanks.
Thank you, Rotarian Asawari. May I request now Dr. Lukena Karkhanis to deliver her address to all of us. Just one thing before we start, in case there are any questions, please type them in the chat box, and please keep your system on mute so there are no disturbances during the address. Over to you, Dr. Lukena Karkhanis.
Thank you very much, Rotarian Jahangir. And I would like to thank the Rotary Club of Mahi Mumbai and Dr. Inamdar and all of you who have signed in for giving me this opportunity to present about the COVID vaccine. As rightly mentioned, this is of great importance to us now. This topic has suddenly become one of the leading topics that everybody needs to be thinking about. So let's start with a little bit of background, okay? What is the COVID-19 pandemic? So COVID-19 pandemic, which is also called the coronavirus pandemic, is an ongoing pandemic of the coronavirus disease 2019, which is the full COVID-19. And it's caused by a virus called severe acute respiratory syndrome coronavirus 2. So SARS-CoV-2 is the technical name of the virus that causes this disease. The virus was first identified in December 2019 in Wuhan, China. So it's been over a year since we've been dealing with this. And the WHO declared the outbreak a pandemic in March 2020. So we are 10 months into the pandemic. As of 27th December 2020, there have been more than 80 million cases with almost 2 million deaths attributed to this COVID-19 disease worldwide. And this pandemic has caused global social and economic disruption, including the largest global recession since the Great Depression. The Great Depression happened after World War II, and after that, it's this pandemic. So hopefully it will be a once in a lifetime event, but it has really disrupted human life across the world in all the countries. So let's talk a little bit about the virus, okay? Not to get too technical, but just looking up a few background information will help us with our questions later. So this is a pictographic representation of what the SARS-CoV-2 virus looks like. It comes from a family called Coronaviridae, that is coronaviruses. It is an enveloped virus, so it has an envelope, and its genomic material, its genes are made of a single strand of RNA. No DNA in this virus. So it's a RNA virus, okay? It's pretty small. The RNA is only about 30,000 bases in length. And the virion, or the viral particle, so one single coronavirus, is about 50 to 200 nanometers in diameter. And just to give you a scale, 1 millimeter, right, that we see on our scale is 1 million nanometers. So this virus is very, very small. It's electron microscope size. It has 4 main structural proteins called the spike protein, which in this picture you will see are these shown by these big kind of red triangular spikes. It has envelope proteins on this envelope. It has membrane proteins in the envelope. And then inside it has what are called nucleocapsid proteins, which carry the virus's RNA. And it attaches to various receptors in the human body on our cells. And 2 well-known ones are the ACE2 receptor and another receptor called basogen. And knowing this structure is a little important because this spike protein is what our vaccines are targeting right now. So let's take a quick flashback to like our high school biology, right? What does the human cell look like? It's probably been a lot of years since some of us kind of revised this, right? So our human cell, it has a cell membrane. That's its first layer of protection. Inside the cell membrane, you have a nucleus, and inside the nucleus, you have the DNA of the cell. Now the nucleus has its own nuclear membrane. So it has its own protection around it. Even inside the nucleus where the DNA sits, it's not just floating around free. It's wrapped up with various proteins called histone complexes and other things. And it's really, really well protected and tucked away inside the cell. So it does not come in contact with extraneous material very easily. Our body has developed a great kind of protective system because our genes are very important to our survival. Outside of this nucleus, in the rest of the cell, that's called the cytoplasm, you have various different organelles or small structures that carry out the functions of the cell. And you have what are called endoplasmic reticulum, you have lysosome, Golgi apparatus, mitochondrion. All of these have very specific functions important to the life of the cell, the survival of the cell, and the function of the cell. So think about it this way, your DNA is inside a safe in your house, right? So any random piece of paper that comes into your house cannot get into your safe. It requires somebody who knows where the safe is, who knows the combination to the safe, who wants to put that piece of paper in the safe for the piece of paper to go into your safe. So our DNA is very, very protected. Now, how does this DNA get converted to mRNA, and how does that mRNA turn into protein, right? So our cells did start making mRNA and protein now because we came up with mRNA vaccines and we came up with coronavirus vaccines. This is literally what our cells do. From birth to death, they take DNA, they make mRNA, they make protein. That is literally their function. Our cells are protein making factories, and they've been doing this all their life. So this process is nothing new to them, okay? So the DNA that usually exists as a double strand with very specific markers and enzymes, the strands separate. The DNA unravels when it's time to make mRNA. And then the DNA gets converted with an enzyme called RNA polymerase to mRNA. Okay, this is called transcription. This is happening all the time in our cells because our DNA is the blueprint, but ultimately to make protein, you have to turn the blueprint into actual operating procedures. You need to give instructions. So that's the mRNA is basically the instructions. The body looks at the blueprint, converts them into instructions. The mRNA instructions then leave the nucleus and they come out into the cytoplasm. And in the cytoplasm, we have these very specific structures called ribosomes, which are our protein making factories. And they have the ability to read these instructions that have been translated, and they start attaching amino acids, one after the other. Depending on what information is carried in the mRNA message, they find that specific amino acid and they start making a chain. And that chain, that polypeptide, is what ultimately becomes a protein. And this is all proteins, right? Proteins that make up our skin and lungs and organs and blood and all our hormones, everything is made this way. And you will see that the coronavirus vaccines use this very basic mechanism to make the spike protein and then induce an immune response. So this is nothing new for our cells. They know how to do this very, very well. Now, I'm going to simplify this diagram for you, but this is a basic representation of what SARS-CoV-2 does. How does it infect a cell? So if one were to catch COVID-19 infection, right, the SARS-CoV-2 virus, which has these little spike proteins on its surface, it's floating about. These spike proteins anchor onto receptors on our cell membrane. And that's why the spike protein is important, because this is what anchors the virus. Otherwise, it would just flow right past our cells. So the spike protein attaches to the receptors, like the ACE2 receptors, which then allows the virion or the virus particle to enter in through the membrane. Once it enters inside, it starts releasing its RNA that is inside, its genome, okay? And that RNA floating in the cytoplasm, our ribosome factory looks at it, thinks, well, it's an RNA. What do I do with RNA? I make protein. So it gets picked up and they start making protein. And the ribosome doesn't realize it's making COVID protein and not human protein. It's just making protein. That's what it does, okay? But if this is an infection, this is a live virus, then it's also able to replicate. So it's able to make more and more and more copies of its genome and ultimately make all the proteins that are needed and then get assembled into new virus particles. So the virus basically hacks our protein making mechanism, our machinery, to make more copies of itself, and that get released from this infected cell, go infect the neighboring cell, and so on and so forth. And this is how the virus invades our body, okay? So what is a vaccine, right? A vaccine is any biological preparation that provides active acquired immunity to a particular infectious disease. Typically, it contains an agent that resembles the disease-causing microorganism. It's often made from weakened or killed forms of the microorganism, or its toxin, or one of its surface proteins. It's supposed to stimulate the body's immune system to recognize the agent as a threat, destroy it, and further recognize and destroy any of the microorganisms associated with that agent that it may encounter in the future. So that's the basis of the field of vaccination. You train the body's white cells, you train the body's soldiers to recognize, destroy, and always remember for the future. Vaccination is the most effective method of preventing infectious disease. We've already established this over the past century. And widespread immunity due to vaccination is largely responsible for the worldwide eradication of smallpox and restriction of disease such as polio, measles, and tetanus from much of the world. And including the coronavirus, we have licensed vaccines for currently about 29 human infections. There are various other animal vaccines, but about 29 human infections. What are the main types of vaccines? And we will be talking about various types today. So we have DNA or RNA vaccines. Basically means that we took the blueprint of the microorganism that we are fighting against, and this is going to teach our immune system to fight. You can have a live attenuated microorganism. So you take the actual virus or bacteria that you're trying to fight and you just weaken it, and you can use that as a vaccine. You can have an inactivated vaccine, meaning you take the virus or the bacteria and you kill it. And then you use that killed microorganism to stimulate the immune system. You can have what are called subunit vaccines. So you can take just one part of the virus or bacteria and inject the body with it, and the body will learn to react to just that one part. And then you have viral vector vaccines, where you take a harmless virus and you insert the DNA or RNA that you want into that virus's gene, and then you use that virus to deliver the message to the body. Now, why do we have to do this? We have to do this because vaccines are a fine balance between what's called immunogenicity, so the ability to trigger an immune response, and pathogenicity, the ability to cause disease. So we want a vaccine that is very, very immunogenic. It triggers an immune response, but not pathogenic. We don't want the vaccine to cause a disease. If we just inject proteins, very often they get lost. Our immune systems are so good at wiping out foreign things that sometimes our body doesn't get a chance to even mount a good immune response. So you have to have a mechanism of delivery of the message to the immune cells. And that's why we try to use viral vectors, or we try to use subunits and things like that. So let's look at the mRNA vaccines that have been used in America right now. There are two approved, right? The Pfizer Biotech vaccine, it has a fancy name, tocilizumab, and the Mrna vaccine, which has a very simple name, mRNA-1273. These are both mRNA vaccines. So what they've done is they've taken the spike protein gene from the coronavirus, made the mRNA, okay, and they've put it inside a lipid envelope. That's all that vaccine is. It's the mRNA, the message how to make the spike protein for the coronavirus inside a lipid envelope. How is that going to work? So when we get that vaccine, the lipid envelope is important because that is what attaches to our cell membrane. If we were to just put the mRNA, it would be destroyed in literally seconds. mRNA is very, very fragile. So scientists that work with mRNA will tell you it is actually a pain. They have to always keep it on ice. It's always getting destroyed. That is also why these vaccines have to be frozen, because mRNA is very fragile. So to even get it to last long enough to reach our cells, they have to put it inside a lipid envelope. It reaches the cell, the lipid envelope releases the mRNA, and like always, our cells have ribosomes. They look at mRNA and they're like, what do? I make protein. So they start making the protein, that the message that the mRNA carries, and that's the spike protein. So they end up making coronavirus spike protein. They don't know what to do with that protein. So some of it gets sent to the surface of the cell because the cell thinks, well, maybe my neighboring cell will know. So these are kind of mechanisms that our body has developed. If the cell doesn't know what to do with something, it sends it out to the surface. Some of it gets chewed up because the cell thinks, maybe this is a danger to me. So there is an apparatus called the proteasome and the lysosome that chews up things that the cell doesn't know what to do with. These are even old and aged cell organelles, old and aged mRNA that might be defective, that might have gotten broken down, and the spike protein. They're all getting chewed up into small little parts called peptides. And then these are picked up by very specific receptors that our cell carry. which are called MHC or major histocompatibility complex receptors that all our cells have, which then wait for our immune cells to come and start recognizing. Okay, so this is what the mRNA vaccine does. It basically tells your ribosome to make spike protein. Some of it goes to the surface, some of it gets chewed up. How do viral vector vaccines work? So this is the AstraZeneca vaccine that has been approved in India, right? The Covishield is the name given in India. So this vaccine has a chimpanzee common cold virus. So it has an adenovirus that they have taken from chimpanzees that does not affect human beings. And in chimpanzees, it just causes a minor common cold. It doesn't really, it's not fatal. And they have put the gene for the spike protein of coronavirus inside that virus's gene. Now, this virus, right, it's a virus, it knows what to do. It goes into your body, it enters, it actually goes to the DNA because that chimpanzee common cold virus is a DNA virus. It goes into your nucleus, where then that virus's DNA gets made into RNA. That RNA then leaves the nucleus, comes outside, sees the ribosome starts making all the messages. It makes spike protein. It's also going to make the proteins of this dead chimpanzee common cold virus, but it's not going to affect us because it's not a human virus. So it's just going to get destroyed, but it's going to make all the proteins. They will again be put out on the surface of the cell. Some of them will be chewed up and the peptides will be displayed on what are called MHC receptors. So this is how the AstraZeneca vaccine works. How do inactivated vaccines work? So this is the vaccine that Biotech has developed called Covaxin. It's basically taken the coronavirus and killed it. So it's a killed inactivated virus. And that's what they propose to inject, a killed inactivated coronavirus, the SARS-CoV-2. So this virus cannot replicate, obviously. None of these vaccines are replicated. They're all non-replicative, right? When the body sees dead material like dead viruses floating about, right, certain cells called macrophages and monocytes, they start engulfing this because they think it's debris. It's all dead debris floating around, it's garbage, and they want to protect the body. So they start ingesting all this dead material and they start breaking it down. They start digesting it. And then all of the proteins inside get split up into their individual parts. And the cell then puts them on the surface and waits for immune cells to respond. So this is how inactivated vaccines work. And we have various inactivated vaccines like polio vaccine, the rabies vaccine, the flu vaccine that we already use. So this is how they all work. Now, once you got those spike proteins on the MHC receptors on the cell surface, what happens then? So the antigen then is seen by what's called an antigen presenting cell, right? Antigen presenting cells are special cells of our immune system like dendritic cells, and they are able to break down that information of that spike protein into its individual peptides, load them onto MHC receptors, and then they are able to pass the message on to the actual soldiers of our body. So the soldiers of the immune system are lymphocytes. They are a type of our white blood cell called lymphocytes. There's two main types. There are B lymphocytes and there are T lymphocytes, and they each have very specific functions. But the beauty is that they are able to recognize these peptides and spike proteins sitting on antigen presenting cells, muscle cells, wherever you got the vaccine, surface of the cell. These B and T cells that we developed during infancy, not even infancy, before we were born. When we were in the uterus, our body developed these immune cells, right? They recognize these proteins and they mount an immune response. So B cells do this by making what we call antibodies, which then will go around, circulate and kill all the cells that have spike protein on them. And then some of them will go on to form what are called memory B cells. So it will be like the body doesn't know it's a vaccine. The body thinks, no, we are infected with coronavirus. We have all this spike protein floating around. What's going on? So they're going to kill it currently. And then they're going to form memory cells to remember for the next attack. So the next attack, we don't start from square one. We already are several steps ahead and we remember what to do, what antibody is going to kill the spike protein. Similarly, T cells, there are various different types. There are helper cells and killer cells. They go and kill the cells that currently have spike protein on them. and they form memory T cells to remember for the future what to do if they see that spike protein again. We are not starting from square one. So this is how vaccines basically trigger an immune response. It's with antigen presenting cells and B cells and T cells. Now let's talk about the COVID-19 vaccines, okay? So the ones in the US. So in December 2020, the US FDA granted emergency use authorization to Pfizer BioNTech for age 16 and above and Moderna for age 18 and above for their COVID-19 vaccines. These are both mRNA vaccines. They have no live virus. They are non-replicated. That means whatever dose of mRNA you get, that's it. It's going to give the message to your body. It's going to be degraded. New mRNA will never be made in your body. They both have that lipid nanoparticle, like we discussed, that's needed. Otherwise, the mRNA will be destroyed in the vial. They are preservative free. There is no preservative, no adjuvant, nothing in these vaccines. And the mechanism is that mRNA just basically shows your body cells how to make that COVID spike protein. And that protein then initiates the immune response. Now, mRNA is a random piece of paper. It's never going to enter the safe. So it never enters the nucleus of the cell. It does not affect or interact with our DNA, and it's not going to turn us into coronavirus. And almost 4.5 million people in the US today have been administered these two vaccines. That's still low compared to what we were expecting, but it's a pretty high number. Let's look at the COVID-19 vaccines that are coming in India. So in January 2021, India's Drug Controller General approved AstraZeneca's Covishield and Bharat Biotech's Covaxin for use. Now, Covishield, AstraZeneca, like I mentioned, it is an adenoviral vector vaccine. It is a replication deficient chimpanzee common cold virus with the SARS-CoV-2 spike protein gene. It has no live virus in it. And Covaxin, which is Bharat Biotech's vaccine, is the inactivated SARS-CoV-2 virus. So they took that COVID-19 virus and they doused it with a chemical called beta-propiolactone. This chemical goes and binds to all the genes, the RNA, the DNA, whatever you douse with. It inactivates replication. So the virus is no longer able to replicate, but it does not destroy the protein. So the proteins remain intact, okay? So there is no live virus, but it has all intact proteins in the particle. This does require what's called an adjuvant. So because vaccines have to have immunogenicity, we often have to add substances that will kind of mark the vaccine as a target for immune cells, and those are called adjuvants. So the Covaxin has an aluminum-based adjuvant added to it. Now let's compare these vaccines. Again, I will simplify the slide. So we have Pfizer BioNTech, we have Moderna, AstraZeneca, and Bharat Biotech. So the first two are mRNA. AstraZeneca is adenovirus, and Bharat Biotech is inactivated virus. Let's look at their trials. So Pfizer got 43,000 participants. Moderna got 30,000 participants. AstraZeneca did 4 trials in UK and South America, and they got 23,848. So almost 24,000 participants. And Bharat Biotech, their phase 3 trials are not yet published, but they claim to have about 23,000 participants, okay? So lots of participants, thousands and thousands, tens of thousands of people have been in these trials. They are all placebo-controlled, randomized, double-blind trials. Now, Pfizer looked at 7 days after second dose, so 2-dose vaccine, and 7 days after second dose, they looked to see how effective their vaccine was in preventing symptomatic lab-confirmed COVID-19 disease. So that means anybody in these trials, no matter whether they got vaccine or placebo, if they complained of any symptoms, they were told to get a COVID test. So they, they could literally call and say, well, my nose was running for 5 minutes. Go get a COVID test. I had a scratchy throat when I went outside. Go get a COVID test. So they were testing these people for the smallest of symptoms. And Pfizer saw 95% efficacy 7 days after second dose. Moderna saw 94.1% efficacy 14 days after second dose. Now, why the difference? That's just trial design. That's just the time they chose to look at. It doesn't mean that it was 0 at 6 days or 0 at 13 days or anything like that, but that's the time they chose to look at when they initially designed their trials, okay? But safe to say that in about a month and a half, these vaccines are about 94 to 95% efficacy. The AstraZeneca data is a little harder to condense because they did 4 different trials. Some of those trials got a lower dose initially, called a low dose, and then the standard dose as the second dose. Some trials got standard dose first time and standard dose second time. Some of the vaccine arms were actually supposed to be a single dose arm. They were trying to see if they can get away with doing just 1 dose, which will simplify matters. But when they saw the responses from the arms that were getting 2 doses, they went back and did a protocol amendment and they gave everybody in the vaccine trials a second dose. So it's a little harder to condense it, but basically after 2 doses, they saw 70% protection. And after at least 1 standard dose, they saw about 64% protection. Bharat Biotech, again, hopefully their data will come out soon. They claim that their phase 3 trials have been concluded, so we will be watching out for their data. But from their phase 2 studies, which are basically safety studies, they claim that their Covaxin showed long-term antibody and T-cell memory responses up to 3 months after vaccination in phase 1 volunteers, and they showed tolerable safety outcomes with enhanced humoral and cell-mediated immune responses in phase 2 study. So they're basically saying that it's going to work, okay? We are waiting for the actual data, but they claim that it will work. Now, Pfizer, Moderna, they saw no difference in this efficacy when they split their participants by age, so young, middle-aged, old, sex, so male, female, race. They had Caucasian, they had African American, they had African, they had Asian, they had Native American, they tried to get they had Hispanic, they tried to get a very kind of representative population. They saw no difference in any particular subset. The vaccine seems to work equally well. Underlying medical conditions, it seems to work equally well, whether you're healthy or you have heart problems, you have diabetes, you have kidney disease, you have COPD, the vaccine seems to work equally well. So in Pfizer trial, in the vaccine arm, right, which is about a half of those 43,000, there were only 8 COVID cases in the 2 months that they followed these patients. In the placebo arm, there were 162 COVID cases, right? So the vaccine made a big difference, 8 versus 162. Moderna, 11 cases in the vaccine arm, 185 in the placebo arm. So again, vaccine made a big difference, 11 and 185. The only difference is one got vaccine, one did not. Moderna also looked at what are called asymptomatic infection, which is what we all worry about, right? Like if somebody is sick, we know to take precautions, but what if somebody doesn't even know they have coronavirus because they are showing no symptoms? Will they still spread it? So Moderna even saw a decrease in the asymptomatic infections. They didn't look at enough. So this data is not significant numbers, it's small numbers, but it was 14 in the vaccine arm, 38 in the placebo arm. So there is signal here that the vaccines are also reducing the tendency to be a carrier or a spreader without symptoms. In AstraZeneca, they saw 63 cases in the vaccine arm and 150 in the placebo arm. So all of these vaccines did show big differences in the vaccine and placebo arm as far as COVID-19 cases. They all then went to look at severe COVID-19 because, you know, if coronavirus were to only cause a common cold, who cares about it then? What we don't want is we don't want people ending up in the hospital, ICU, dying, needing lung transplants, that kind of thing. So Pfizer had 1 case noted as severe in the vaccine arm, but even that case, when I looked in detail, really recovered at home. It was just that one time their oxygen reading was low and so they were defined as a severe case, but they recovered at home. They were really a mild to moderate case. They had 3 severe cases in the placebo arm. Moderna had 0 severe cases in the vaccine arm, 30 in the placebo arm. AstraZeneca had 0 in the vaccine arm and 2 in the placebo arm. So there is definitely evidence that not only does it prevent coronavirus infection, if you were to catch it after the vaccine, you are highly unlikely to get it severely. So it will also decrease the intensity of infection. Now let's look at side effects. Everybody's worried about side effects, right? So Bharat Biotech, they just claim that their phase 3 trials show that they were well tolerated in both dose groups with no serious adverse effects. We will wait for their data and hopefully it will be good. The Pfizer, Moderna, and AstraZeneca, pretty much side effects were what you would expect after any vaccine, right? We are never going to have a vaccine or a medication with zero side effects. That's just not possible. With effect comes side effect. Even oxygen and water have side effects. So if you want something that has efficacy, it is going to have a little bit of side effects. So the common side effects were injection site reaction, fatigue, headache, muscle pain, chills, joint pain, fever, feeling feverish, things like that, okay? Nothing unexpected. This is what we tell our patients routinely when they get any vaccine, right? You may feel a little sore at the site for a day or two. You may feel a little bit of chills, things like that. So nothing new compared to other vaccines that we've been using for decades. Now, Pfizer and Moderna both reported lymph node swelling. So the arm where the vaccine was given, volunteers in both the vaccine and placebo arms did report that their lymph nodes got swollen a little bit. All of these cases resolved, okay? And again, this is not unexpected because our lymph nodes are the main centers where our immune response is being mounted. So you can imagine if you put a vaccine in the arm, then that arm's lymph node is going to become very, very active because it's starting to fight the spike protein. So a little bit of lymph node swelling is not unexpected again, and it all resolved. A lot of people have lots of questions about Bell's palsy. So Bell's palsy is a condition that affects the nerve of the face, right? In Pfizer trial, there were 4 cases of Bell's palsy in the vaccine group, none in the placebo group. But if you think about it, they had over 40,000 people. So people in general get Bell's palsy. Bell's palsy is not that uncommon even in the general population. And this 4 in the vaccine group, really the incidence is not higher than general population. So again, this is being monitored, but there is no reason to think that the vaccine caused the Bell's palsy. In the Moderna, there were 3 cases of Bell's palsy in vaccine group, 1 in placebo group. Again, the incidence is not that expected just if people had never entered the trial because they had 30,000 people. There were no cases of Bell's palsy in AstraZeneca as far as I could see. Now, Pfizer, they had maybe 1 shoulder injury. So it's technique dependent. The person giving the injection needs to give it at the proper place. They saw no anaphylaxis. So the trials really showed no severe anaphylaxis or no severe reactions, no deaths. Moderna, very interestingly, they had 3 cases of facial swelling in participants who had dermal filler injections. So dermal fillers are a cosmetic procedure often done on the face like Botox for anti-aging and cosmetic purposes, or wrinkles basically. And 3 people who had these dermal fillers previously reported that they got facial swelling after the vaccine. Now, my dermatology colleagues tell me that there seems to be something about dermal fillers in general, because even before COVID infection, before coronavirus vaccine, they used to see cases of swelling with dermal fillers with just any viral infection. There were some patients who would swell up with flu or any virus, okay? So this is something to keep in mind and warn your patients about. It was all temporary and it resolved. They saw some intractable nausea, vomiting. Again, it's unclear whether it was related to the vaccine. AstraZeneca, and if everybody remembers, for a while their trials were halted. They reported 3 cases of transverse myelitis. So transverse myelitis is a condition that affects the spinal cord. Basically, people thought they were paralyzed. So they investigated these and 2 were unrelated to the trial. The causes for the spinal cord problems were unrelated to the trial. 1 was thought to be idiopathic, meaning we don't know the cause. So none of those transverse myelitis cases were actually attributed to the vaccine. And that's why they started the trials again. Okay? So in general, the takeaway is that these 3 vaccines were very, very closely scrutinized. So if you look at the data, I did not put it all on here, but they looked at every little thing. And, you know, they had people from ages 16 to like 95. So yes, there were people that got into car accidents. And yes, there were people that had appendicitis. And yes, there were people that had heart problems. But that was because that's what happens to people, right? So association does not equal causation. So just because two things happen to a person at one time does not mean one thing caused the other. So we are talking right now on Zoom, it may start raining, does not mean that the Zoom meeting caused the rain. So no big adverse effects related to vaccine were seen in any of these trials. The data seems to indicate that these are very safe vaccines. Let's look at pregnancy and breastfeeding, because a lot of people are questioning that, right? So the first 3 trials, Pfizer, Moderna, AstraZeneca, they excluded pregnant women. And that's not unusual. We as a society are extremely cautious and protective of our children. So pregnant women, breastfeeding women, and young children are often excluded from the initial trials because we don't want them to be in the initial trials when we don't know what's going to happen. So they excluded them from the trials. However, at least in Pfizer and Moderna, women still got pregnant, right? Because it happens, it's live. So women participants, female participants, unwittingly still ended up getting pregnant after getting the vaccine or placebo injections in these trials. So 23 women in Pfizer trial and 13 in the Moderna trial did end up getting pregnant after getting the doses. And all the vaccine arm pregnancies are doing fine so far. So 12 in Pfizer, 6 in Moderna, their pregnancies are doing fine. And we will just follow them for the rest of their pregnancy. There were some losses, birth losses in the placebo arms, but they were unrelated to the placebo. I mean, it was not COVID-19 that caused these losses, but all the vaccine arm pregnancies unexpectedly got pregnant after getting the vaccine. They're doing fine. So what is the current recommendation? So for high risk people, like essential workers, healthcare providers, doctors, nurses, staff that are very high risk for catching COVID, the recommendation is that you take the vaccine, right? Because COVID infection in pregnancy is catastrophic. It can be catastrophic. Mom will end up in the ICU, baby may be born premature, all kinds of problems will happen. So what are you going to take your chances with? The vaccine seems very safe and it will help. And in fact, when mom's body makes the antibodies in the 3rd trimester, some of that protection will pass through that placenta to the baby. And then for a few months after birth, the baby will have some protection against coronavirus. So the thought is that if a pregnant woman wants the vaccine, they should get the vaccine. We will wait and look at AstraZeneca and Biotech's data. They did not put out their data yet regarding pregnancy. They just say that women were excluded. What about breastfeeding moms? So the recommendation, again, at least in America, is that if you are high risk, if you want to get the vaccine, please get the vaccine. There is no plausibility that the mRNA will do anything bad to the baby. Number one, mRNA is very fragile, like we discussed. I mean, it needs to be frozen. As soon as it enters the body, it just gives your ribosome the message. It's gone. It's gone within days, it's gone. It's not going to survive and circulate in your body for months and months. It's not going to go to the breast milk. It's not going to go to the baby. It's not going to go to the placenta. So the mRNA, the beauty is that it's very fragile. The problem also is that it's very fragile. It's taken almost 2 decades to develop these mRNA vaccines. We think they were done so quickly, but the scientists have been working on them for almost 20 years for other things like malaria and things like that. So it has taken that long to even stabilize the mRNA enough to just deliver the message to the cell. So it's not going to do anything bad to breast milk or to the fetus or to the baby. Now keep in mind, right, babies that are breastfeeding, they are catching colds. They are ingesting and inhaling viruses from the environment because that's what happens. It's human life. You're born and you got to start fighting all the infections off the bat. And many of these have DNA and RNA, and the body is just digesting it, breaking it down. That's why our stomach has acid. We have all these digestive enzymes. So RNA, DNA, by the time it gets in our mouth, it's gone. So for pregnant and breastfeeding women that are high risk or that want the vaccine, the recommendation is to give them the vaccine because it definitely seems safer than actual coronavirus infection. What about the logistics? So this is where there's a lot of difference. So Pfizer, there are 5 doses in a vial, and it has to be stored at very, very low temperatures, -80 to -60 centigrades. So very low temperatures. Moderna, 10 doses per vial, but it can be stored in your regular freezer, -25 to -15 centigrades. AstraZeneca actually can be stored in the fridge. It does not need to be frozen. So 2 to 8 degrees centigrade, your fridge at your house can keep the AstraZeneca vaccine. Bharat Biotech also claims that it will be refrigerated, so 2 to 8 degrees, so in your fridge, but we don't know for sure yet. Now, Pfizer needs to be thawed, diluted, and the dose is 0.3 ml. Moderna, there is no dilution. You just thaw it, it's ready to go. The dose is 0.5 ml. Now, Pfizer requires 2 doses, 21 days apart. Moderna requires 2 doses, 28 days apart. AstraZeneca is saying 2 doses, 4 to 6 weeks apart. But some participants in their trial got the dose as much as 3 months apart, because remember I had mentioned they went back and gave a second dose to the single dose arm because they saw that the 2 dose arms were having good results. So I think they will come out with a 4 to 6 week recommendation, but some people did get it 3 months apart. Pfizer, prior to first use, you can thaw in the fridge and keep it for up to 5 days, and then you have to use it up. Moderna is up to 30 days, and AstraZeneca is 6 months. And then once you open these vials, so once you pull out the first dose, Pfizer, Moderna, you have to use it up in 6 hours. So you better have your patients lined up when you pull out the first dose, because you do not want to waste that last or second to last dose. AstraZeneca, I still don't know, once they pull out the first dose, how long that vial is good for. Neither do I know for Bharat Biotech. This is going to be a big consideration in India, I think, because these ultra low freezers, -80 to -60, are expensive, and a lot of our hospitals even may not have them. Moderna is a regular freezer, so the hospitals will have them, but primary healthcare facilities, rural healthcare facilities may not necessarily have a freezer. That's where AstraZeneca and Bharat Biotech may win out, because almost everybody has a fridge now in India. So fridges are not that rare. Let's look at advantages and disadvantages. So when you compare them, right, Pfizer and Moderna mRNA, then you have AstraZeneca viral vector, you have Bharat Biotech inactivated vaccine. So what are the advantages of mRNA vaccine? They seem to offer very robust protection, 94 to 95% efficacy. That is very, very high. If you think about it, our flu shot that we take every year that saves millions of lives has about 50% efficacy. So this is almost double that. They're very, very robust. They're easy and quick to design, because all you are doing is you are designing the message for your system. They are less prone to contamination, and they're actually cheaper to manufacture. Now, why is this, right? So think about it this way. If you have a friend who has a very bad food allergy, and they say, I really like your cake. If you are making a cake for them in your kitchen, you will always worry about contamination, because you will worry, oh, they're allergic to egg. Did I use this pan for eggs yesterday? Did I clean it properly enough? Are they allergic to milk? Was the spoon just in the butter? Did it touch some milk somewhere? Oh, did I clean out my oven properly? You will always worry about contamination. So when you're making a viral vector vaccine or an inactivated vaccine, you're making it in a cell line, because you cannot make this just in the lab without cells. All these vaccines, these viruses, require animal or human derived cells to make them. And then you have to worry about, did you get that particular protein out correctly without all the millions of other proteins in that cell line in the lab? Did that cell line make it the same way that your body would have made it? Did it contaminate it with some other protein from its own cell? Did it warp it? Did it degrade it, right? So when you're making that cake in your kitchen, you keep worrying about contamination. As opposed to that, you can just give the recipe to your friend and say, you have food allergies, your house, your kitchen is set up for your food allergies. Here's the recipe, you go make it on your own, and you will make it best the way it suits you. And then you're done, that's it. And that person will be happy because they can make it on their own. They know they're allergic to eggs. An egg has never entered their house. They know exactly what suits them. That is what it is. So mRNA, you just give the message to your cells, and then your cells can make the spike protein way that's best for your body. So that's one of the main advantages. That's why they are less prone to contamination. They are cheaper to manufacture. What are the disadvantages of mRNA vaccines? They are new. So people are scared because they are new and they need to be frozen. A lot of people ask why the difference between the temperatures for the Moderna and the Pfizer vaccine. Why is the Pfizer so much lower temperature? So think about it this way. They both have lipid envelopes. Those lipid envelopes are what need freezing along with the mRNA. And one has, for example, an olive oil envelope. And one has a coconut oil envelope, right? And we all know that olive oil requires way lower temperatures to freeze than coconut oil. That's basically what it is. So their lipid envelopes differ, and that's why one requires a lower temperature to stabilize and one is okay at a slightly higher temperature. What about viral vector vaccines? The advantages are good protection, not 94, 95%, about 70%. But again, like I said, that's very, very good compared to zero without vaccine. Another advantage, no need to be frozen. You can keep them in your regular fridge. Disadvantages, they are new. They are new just like the mRNA vaccine. So very few viral vector vaccines have been developed. Ebola, rabies, not really used worldwide. The second problem is you're using that chimpanzee common cold virus, right? Your body is going to mount a response to everything in that vaccine, not just the spike protein RNA, but the chimpanzee DNA as well. And eventually you are going to mount a response and you're going to start killing off that vector. Okay, and then you have to be sure that the vector is safe. The vector is not one day going to suddenly cause common colds in humans. So that's a disadvantage of viral vector vaccines, is that people may start mounting a response to the vector and the vector may not be safe. Right now, the AstraZeneca vector, nobody has an immune response to it because, like I said, it's not a human virus. It's a chimpanzee virus, and it seems to be very safe. Inactivated vaccine, so the Biotech vaccine, what are the advantages? It's an old technology. We've been using polio and flu vaccines for decades and decades. There is no need to be frozen. It can stay in your fridge, so logistically easier when you don't have a freezer in your office. What are the disadvantages? It's old technology. So we don't know how effective it will be. It's very old technology compared to viral vector and mRNA vaccines. We don't know how robust the protection will be till we get the phase 3 data. You need adjuvants. That tells us that this vaccine by itself is not strong enough. You have to add that aluminum adjuvant to mark it as a target for your immune system so that they can mount a response. So those are the disadvantages. You require an adjuvant, which may cause reactions in people, and then the immune response may not be as robust. So we will wait for that. So let's look at some questions. So these are the common questions that I keep getting. So I just put some of the common questions here, but if I'm missing any questions, please ask me after. So one question is, if I already had COVID-19, should I get the vaccine? Short answer, yes, you should get the vaccine, right? The vaccine was safe and efficacious. So they did look at people who had prior COVID infection. If they had known infection, they were excluded from the trial, but in spite of that, ended up entering the trial with unknown infections. And there was no difference in the safety and efficacy. Side effects, effectiveness was same in people who had never had COVID versus those who unknowingly had had COVID. So we offer the vaccine to everybody, regardless of history of symptomatic or asymptomatic COVID infection. And we do not check for evidence of antibodies or previous infection before giving the vaccine. There is no need for that. If I have had COVID, when should I get the vaccine? So you should wait till you've recovered from your acute illness, right? Because you are already sick. You do not want to be taking a vaccine when you're sick. Wait till you have recovered enough to discontinue isolation. So right now, CDC criteria are 10 days for mild cases, as long as you are fever-free for 1 day without any fever-reducing medications, and your other symptoms have started to improve. Some symptoms like loss of smell and taste take months, so you don't have to wait till they're completely gone. but they've started to improve. So for most people, they can get the vaccine around 14 days after a mild infection. Now, if you had a moderate or severe infection, that changes because you might be in the ICU and things. If you wanted to wait, if you did not want to get the vaccine right away for some reason, then there is a possibility that for about 90 days after your infection, you may do okay. This has not been proven in studies, but this is what we think. This does not always hold out, but if for some reason you did not want to get the vaccine right away and you wanted to wait a little bit, don't wait beyond 90 days, okay? The only reason to wait would be personal preference. There is really no medical reason to wait after a COVID infection. As long as you have recovered enough, you're out of isolation, you should go get the vaccine. Should immunocompromised patients take the vaccine? Yes, they should take the vaccine. Now you have to stabilize these patients first. You cannot have somebody who is acutely sick take any vaccine, not just coronavirus vaccine. But once the patient is stable, so people who are chronic immunocompromised on medications but stable, they should take the vaccine. It is not a live vaccine. It is not going to give them COVID infection. Think about it this way, right? Our choice is not between vaccine and placebo. In real life, our choice is, like Dr. Inamdar mentioned, how are we going to fight COVID when we catch the infection? With vaccine protection or unprotected? That is our choice. When I catch coronavirus, do I want to have some pre-existing protection already from the vaccine, or do I want it to be a surprise test for my body? I do not want it to be a surprise test for immunocompromised patients because they're already low immune system and they will not do well with a COVID infection. So whatever little bit of protection they can get from the vaccine is going to help. Every little bit. So yes, low immune patients, immunodeficiency patients, patients on immunosuppressant medications should take the vaccine. My practice still hasn't heard when we will get our shipment, but our city is vaccinating now. There have been various claims floating out about that this vaccine will sterilize you. That is utter nonsense, okay? There is no biological plausibility. People claim, oh, the spike protein looks like a placental protein. But just because A looks like B does not mean A is B. I mean, people here think I am from Mexico. I am not. I may look like somebody from Mexico, but I'm actually from India. So just because A looks like B does not mean A is B. There is no biological plausibility. And think about it. If you're scared of spike protein causing sterilization, if you catch COVID infection, it's going to give you 1,000,000 times more spike protein. So that would actually be way worse. So where are you going to take your chances with? The disease that's caused almost 2 million deaths, or the vaccine that has caused no deaths and seems to be very effective? Also, pediatricians are reporting to me that they're getting very busy because we're about 9 to 10 months out from the initial COVID surge in the world, the initial lockdown, March and April, and a lot of babies were conceived during those initial lockdown months. So COVID infection, COVID vaccine does not seem to have affected fertility rate. What about anaphylaxis? So people are worried about dying from the vaccine. So there are about 20 cases of possible severe reactions reported worldwide after the Pfizer vaccine. They are being studied, and I don't know how many of these will truly end up being labeled as anaphylaxis, but they are being studied. But when you look at the fact that about 4.5 million people got the vaccines, 20 cases is a pretty low number, and none of these people died. They were all treated, they recovered, they resolved, they're doing fine, okay? So FDA right now in the USA recommends that you get your vaccine at a place that has the capability to recognize and treat reactions. That should be true for any injection. You should always get it at a place that can monitor you. You monitor the patient for 15 to 30 minutes. If you have a history of a reaction to a medication or a food or a vaccine in the past, just keep in mind, carry your epinephrine auto-injector. Now in the USA, we give epinephrine auto-injectors to food allergy patients. In India, they're not given very commonly, but you basically have to make sure that the place you get the vaccine at knows how to treat reactions. Okay, I'm an allergist. I have a huge population of allergy patients with medication, food, allergies, and things like that. And this is what I tell them when they ask me, should I get the vaccine, right? Any side effect that the vaccine causes you, I can guarantee you that I can treat it. Your doctor can treat it. With coronavirus infection, there is no such guarantee. I cannot guarantee you that I can treat you for coronavirus infection. We do not have very effective treatments yet. So where are you going to take your chances, right? It's a pandemic. We're all going to be exposed. We should get whatever protection we can. There are lots of questions about mutations. We are seeing new strains in the UK and South Africa, right? So luckily, the coronavirus does not mutate as much as our other friend, the influenza virus. The influenza virus, because of the way it is, it can change huge parts of its DNA and RNA very, very quickly. Not so with the coronavirus, thank God. Spike protein is what we worry about because that's what our vaccines are targeting, right? It's pretty conserved across all the strains noted so far. So yes, there have been mutations in the spike protein, but they are small. They are about 8 to 10 amino acids. The whole spike protein is about 1,700 amino acids. So if 8 to 10 of them somewhere change, your body will still recognize the remaining 1,680 or 90 of them, okay? So I think that the vaccine will work against all the current strains that we are seeing. Pfizer, I think, has already shown that its vaccine works against the mutated strains. Think of it this way, right? If you put on some makeup and change your appearance a little bit, a police officer can still recognize you from the photo on your driver's license. So minor changes here and there doesn't mean that the immune system will stop recognizing the whole spike protein. There's a question, will we need the coronavirus vaccine every year like we need the flu shot? We don't know yet. We have to wait and see how this pandemic goes. Large-scale challenge studies are never going to happen. We're never going to take a volunteer group and keep exposing them to COVID infection again and again to see if the vaccine protects them, right? So we need to wait for real-world data. We need to wait for people to just get exposed on their own and then see, do they get infected, do they not get infected? Even without vaccine right now, reinfections are low, which is reassuring. Another common question is, how long does immunity last from this vaccine? Well, the problem with the answer to that is we don't know how to measure immunity to viruses, right? We check antibodies, but we don't know if we are checking the right antibodies because not all antibodies are protected. We don't have a titer established yet. What is the level of antibody needed to be protected? Just because we have it does not mean we have enough. We don't even know if we are checking for neutralizing antibodies. Antibodies, like I showed before, are just one part, B cells. There are T cells that mount a cellular response to viruses, which are often the main response to viral infections. And we don't even have good lab tests to check these T cell responses. So how can I tell you how long immunity will last when I don't even know how to measure immunity, right? That's the big problem. So I think that meaningful measures of immunity will come from data. If we start vaccinating and we start seeing a drop eventually in new cases and hospitalizations and death and reinfection and community spread, that's how we will know that we have got immunity. And then we have to monitor that and see how long does that last. Okay, so it's going to take time. It's going to take time. There are many questions about, will production of the spike protein on my cells cause my immune system to think that other proteins made by those cells are also foreign? So will I develop what's called autoimmunity? Will I start reacting to my own cells' proteins and develop a disease like arthritis or something like that? So this is not going to happen because our cells, while we are still in the uterus, when we are a fetus, they get trained to recognize self proteins. It's almost like military training boot camp for our cells. So they go through, the T cells go through an organ called the thymus, and they are exposed to each and every self protein on each and every organ. The ones that show a capacity to bind to self proteins get destroyed. They get told, you know, you're the security guard. You can't be killing your own people. You will die. So they never even make it to birth, okay? So our cells know very, very well how to recognize self. Now, does this fail sometimes? Yes, very rarely. There are people that develop autoimmune disease, but it doesn't happen because of viral protein on the cell. Because keep in mind, I mean, long before COVID, we were all catching viral infections twice a month. We catch colds and we catch GI infections. Our body, our immune system is working 24/7, 365. Even as we talk right now, it's working. And we are constantly getting viral DNA and RNA, and we're mounting them on cells, and we are mounting an immune response. And given the millions of pathogens that are out there that we encounter daily, if this were to result in autoimmunity, we would die as children, right? Because, I mean, we've seen millions of viruses by the time we are 3 years old. So this does not happen. Just because you have a viral protein on your cell surface does not mean that you're going to develop autoimmunity. Will the COVID-19 vaccine cause autoimmunity? I think it's a very theoretical risk. There is never a 0% chance for anything in nature. But there was one case of rheumatoid arthritis, which is an autoimmune disease, in the trials. And that too, it was like 14 days after the dose. That's very, very quick for rheumatoid arthritis. This is a disease that onset is for years and years before it is diagnosed. So I think this patient probably already had it from before. There were 3 cases of that spinal cord injury, the transverse myelitis in the AstraZeneca trial. 2 were unrelated, 1 was idiopathic. So really we haven't seen any big autoimmune diseases come up so far after the vaccine. Now, a lot of people are concerned about what's called antibody dependent enhancement. What this basically means is, if I take the vaccine first and then I catch coronavirus infection, will I have a worse course with the infection because I have pre-existing antibodies? This was actually seen in a different vaccine, the dengue vaccine, and that's why we don't do dengue vaccine. In coronavirus vaccine trials, no cases were seen. And in fact, like I showed you, the vaccine arm consistently did much, much better with infection than the placebo arm. So there is no antibody dependent enhancement going on over here. The vaccine is actually protecting against infection. And even if you were to catch it, it is decreasing the severity. Will the vaccine integrate into my DNA? So a lot of people are scared that they will become part coronavirus. The vaccine is going to enter their DNA and going to destroy them. This is not going to happen, right? Pfizer and Moderna, like I said, it's an mRNA. It cannot enter the nucleus. A piece of paper cannot enter the safe in your house. The vaccine has no reverse transcriptase, which is the enzyme needed to convert RNA to DNA. So it's not going to happen. AstraZeneca, it's a chimpanzee common cold virus. Like all our common cold viruses, it's not going to integrate into our DNA. It goes to our nucleus, but it still does not integrate into our DNA. It does not have what's called integrase, which is needed to integrate DNA. If common cold viruses were to integrate into our DNA, we would all be viral by now. Biotech, it's a dead virus. It cannot integrate into any DNA because it's dead, it's debris, it's garbage as far as the body is concerned. The beta-propiolactone completely inactivates all the genes. So do not worry about the vaccine changing your DNA. What are the long-term concerns, right? So with mRNA vaccines, like I mentioned, our cells from birth to death are taking mRNA, making protein, taking mRNA, making protein. We are doing fine. So there is really no long-term concern. This is just a temporary little supply of extra mRNA that will last for a few days. It will be gone. Your body is probably not even going to know the difference. mRNA vaccines, like I said, they're more precise, they're less prone to contamination, easier to manufacture, and cheaper. If there were to come a point where we see a coronavirus that has mutated and we wanted to make a new vaccine, the mRNA platform will be the quickest to change the gene. You just take one gene out, put the other gene in. What about adenovirus vector vaccines? Again, it's a common cold virus. We are constantly exposed to common cold viruses and we do fine. So there are no long-term concerns, okay? Inactivated vaccines like the Biotech vaccine, we've been using injectable polio and flu vaccine for decades, right? The main question is, will it work? Not is it safe, it's will it work? If it will work, it's safe. After getting vaccinated, can we discontinue social distancing measures? So no, that is not correct. You still have to wear a mask, wash your hands, sanitize, practice social distancing. Don't have indoor get-togethers with people that you don't live with. Don't have big get-togethers. You still have to do this. Why do you still have to do this? It will keep you from getting sick. It will keep you from getting the infection. But for quite a while, you are going to be around people that are unvaccinated, especially our children. These vaccines are probably only going to be for adults to begin with. So you still have to practice all social distancing measures. The vaccine is not a free pass to stop everything that we've been doing. It is an additional measure to fight the pandemic. Then what about people that have various weird diseases like hives all the time, rashes, mast cell problems, dysautonomia, people that are very prone to low blood pressure and things like that? They need to get this vaccine. The vaccine is probably way safer than actual coronavirus infection for all these people, right? Continue all your medications, your antihistamines. That's what I tell my allergy patients. If you have an epinephrine auto-injector, keep it on you. Make sure that you're going to a place that can treat you, which all places should be able to. They will not be allowed to administer the vaccine if they can't. But everybody needs to take the vaccine. So as they say, you know, the first step to getting ahead is to get started. So we cannot get ahead of the pandemic if we do not start by taking the vaccine. So when it's our turn to take the vaccine, we need to take the vaccine. So that's the moral of the story. How would you rather face an angry bear? So coronavirus infection is like this angry bear that is charging at you. There is no stopping it. It's coming for all of us. Do you want to face it unarmed without any vaccine, or you want to face it with a weapon, with the vaccine? If there is an angry bear charging at you and there is a weapon lying in front of you, it makes perfect sense to pick it up and arm yourself, okay? What is the best vaccine for you? The best vaccine is the one that you can get as soon as possible, right? A very effective vaccine that's sitting in a vial in a freezer 100,000 miles away is pretty useless to us. So the best vaccine is one that has been studied, obviously, and that is available to you. So when it is our turn to take the vaccine, we should take whatever vaccine is available to us that has been studied. Like Dr. Inamdar said, it's perfectly on point. We have to take the vaccine when it is our turn. What will waiting a few months achieve in real life terms? Probably nothing other than the risk to you that in those few months you could catch coronavirus. You could spread it to somebody could die. You or somebody else you love could die. So when it's our turn to take the vaccine, we will take the vaccine. Do I put my money where my mouth is? I absolutely do. This is a picture of me getting my coronavirus vaccine. I got it as soon as it was offered to me. And this hashtag, this is our shot. It's a grassroots movement by doctors. So any doctors present here, when you get the coronavirus vaccine, right, it's mandatory to take a picture and post it. Please use this hashtag. This is a movement to bring back trust in doctors. A lot of patients are untrusting of doctors now. This is a movement to bring back trust in doctors, bring back trust in vaccines by showing you, here we go. We will never recommend to you what we think is not safe for ourselves. Here is proof. We will take it first and show to you that it is safe, okay? So I already got my coronavirus vaccine. These are my references, and I think we can now go to the questions, if that is okay.
I'd like to thank first Dr. Lukena for her content-filled and informative speech, which I think she's done a really great job of removing our fears and anxieties regarding the COVID-19 vaccine. We'd also like to thank her for taking time out of her busy schedule to address Rotary members and our acquaintances. And I think she's basically made this complex subject really easy for us to understand by comparing the various vaccines that are available. So I'd like to thank her for that. I'd also like to thank past District Governor Dr. Bal Inamdar for agreeing to being our chief guest today and encouraging us to set up such informative talks on subjects of current interest and importance. Dr. Bal Inamdar's presence is really a real big motivation for the Rotary Club of Mumbai Mahim, as he's always been one of our well-wishers. I'd also like to thank Dr. Julina for giving our club this opportunity to hear from an expert like her daughter to address us. And lastly, I'd like to thank the President Usha and the team consisting of Anand, Prakash, Sandhya, Vandana, Vidula, Shobha, Surya Kumar, Asavari Kishore, Gurmeet, Seema, Dr. Hemangi, Dr. Sneha, Revati, our Rotractors, and others who have worked really hard to make this program a grand success. The team spirit of our members who have directly or indirectly helped us organizing this event is really commendable. I'd now like to request Dr. Hemangi and Dr. Sneha to conduct the Q&A session.
Just also to thank Dr. Madhukar Bide for gracing it up to the end, and Dr. Maya Kriplani and Dr. Francis from Rotary. Thank you very much. Please go ahead.
Hello, Lukena. Hello.
Yes, hi.
Can you give more information about children? Because there are a lot of difference of opinion. First, it came below 16, you should not give vaccine. Then it came now some trials are starting from 12 to 16 years. And now some reference say they should be given after 2 years only, because though they don't suffer, they are asymptomatic carriers. And when the school starts, they will start spreading it to others and parents. That's why we should start giving after 2 years. So what do you feel?
So there are trials going on. Pfizer for sure has a trial for age group 12 to 16 or 11. Yeah. Interestingly, that trial probably does not have a placebo arm. They only have vaccine arm. So people who register their kids for the trial, they are going to get the vaccine. That is because it is considered efficacious. There is no question that it will help. The only question is, will it be safe? So that's all they're trying to study in that trial. I think the vaccine will come out very soon. I think that trial will have positive results. Of course, we have to wait and see. But once that vaccine is approved, I absolutely believe that the 12 to 16 or 11 to 16 age group should get the vaccine. Now, the spread through school, I would just like to make it clear, after getting the vaccine, you cannot spread coronavirus, okay? Because the vaccine doesn't have any live coronavirus in it. So just because you got the vaccine doesn't mean you are going to spread the vaccine mRNA to someone else. That's not how it spreads.
If children don't get vaccine, they can spread the virus. That's what UK people are saying.
Yes, yeah. Yes, definitely. If they have not been vaccinated, they can spread the virus. Luckily, hopefully, if they catch it, it will be mild. But there are children who get hospitalized. So I think as soon as we know for sure that it's safe, we have to start dropping down the age to whatever is appropriate.
Another question I wanted to ask you. Somebody told me those who are suffering by polio, they have a natural immunity more for this virus because there is some similarity between coronavirus and polio virus. Is it true? Because one or two doctors told me this.
I don't think the similarity is enough to say that. Like I said, just because two things look similar doesn't mean that they will work in the same way. So I don't think the similarity is enough to say, that they will do better with coronavirus infection. In general, people who have chronic health conditions, so if they have polio and they have residual deficits from a previous polio infection, they are probably not going to do well with a bad infection like a coronavirus infection. So absolutely, I believe that these patients should get the vaccine. What will happen, worst comes to worst, is they'll still catch coronavirus, they will get it milder, or they may not even realize they got it, right? So yes, I don't think just because you had the polio infection means that you should not get the COVID-19 vaccine. You should get it.
And somebody had asked question about osteoarthritis. If somebody has a severe osteoarthritis, whether they should go ahead with the vaccine.
They should get the vaccine. Osteoarthritis is not an autoimmune disease. Osteoarthritis is caused by wear and tear of your joints, usually with age and overuse, right? It's our regular arthritis. So definitely you should get the vaccine.
There was a question about rheumatoid arthritis. While we are on that, rheumatoid is what is the autoimmune disease. So then there are patients who are taking like methotrexate and your hydroxychloroquine already, which are sort of like immunosuppressants. So there are patients who are asking that, not just rheumatoid arthritis. I'm just saying it because we're on that example, but other patients who have other autoimmune diseases. Is it safe for them to be taking?
It is safe. I think it is safe because keep in mind, they may not be able to come off their methotrexate or their hydroxychloroquine, right? Because you don't want their autoimmune disease to flare up. You don't want them to be hospitalized, flare up in their rheumatoid arthritis or something. So they stay on that medication.
Right.
Stay on that medication, they're stable, they take the vaccine. Now, may not work as well because we are suppressing their immune system with the or the hydroxychloroquine, but every little bit helps. So like I said, ask yourself, how would you rather this patient fight coronavirus infection, right? They're already immunosuppressed. You want to give what little protection you can give them. So even if they have a less than optimal vaccine response, it is better than 0%. So they should take.
So now that we are very clear about the efficacy of the vaccine, we know that it is definitely mounting some amount of immune response. A lot of people are asking about the safety in patients who have comorbidities like, hypertensives and diabetics, in which it has been so popularized that these people are the ones who have to be more in whom it is documented that coronavirus is causing a more severe disease. And as an extension of that, I have a very interesting question that we received before this talk, that there has been no known phase 3 trials done on Indian population, India being, it's known to be like the diabetes capital of the world, and not even in patients with comorbidities or in patients of the high risk group. And since the risk to benefit ratio hasn't been assessed, how safe would we consider the vaccine for administration in the Indian population?
So part one, right, the Pfizer and Moderna trials did look at comorbidity. So they looked at subgroups that had hypertension, diabetes, chronic kidney disease, COPD, lung problems, and they saw equal efficacy in all these groups. There was no difference. The vaccine, they saw equal safety in all these groups. There was not one group that stood out where the vaccine didn't help or the vaccine was dangerous. So in fact, it is helping all these people for whom coronavirus infection is really dangerous. So definitely hypertension, chronic kidney disease, immunosuppression, lung disease, severe asthma, COPD, heart problems, these patients should take the vaccine. It is just as safe and just as effective in them as it is in other patients. And then, though there are no trials in India, I'm not sure whether Bharat Biotech had any participants in it because the phase 3 data is not published yet. There were Asian American participants in the other trials. So if you look at the ethnicity breakdown, the racial breakdown, there were people of Indian origin in all these trials. And the trials have looked at details about the racial differences. They saw no difference. The vaccine seems to be equally safe and equally effective across races. And that's not expected. If you look at the technology, I mean, mRNA or viral vector, how is race going to matter in that, right? So there were no differences seen in the trials for both groups.
Lukena, they have started the trial in 2 hospitals in Bombay, about 50 years with comorbidity of diabetes and hypertension, but they are not getting enough patients. Patients are not coming forward.
Yes, I think the problem now is that we have approved vaccines. So now people want to volunteer for a trial. They're saying, just give me the approved vaccine, which is human nature. It's not completely unexpected that people will say there's already an approved vaccine. Why should I take the trial dose? And hopefully there will be enough vaccine to go around, because a lot of times, so right, even Dr. Inamdar mentioned, right, how were these vaccines developed so fast, right? And vaccines normally take 2 years, 4 years. The last time a vaccine was developed fast was the measles vaccine. Many years ago, it took 4 years, about 100 years ago. How did this happen in a few months, right? Well, first was means. These trials are very, very expensive, and the governments funded these trials. Normally, these scientists have to go around begging for money, applying for grants, looking for investors, looking for companies to believe in them. Every 1, 3, 5 years, they're looking for money. The government funded them, gave them all the money, so they didn't have to worry about the money. Second, right, was motive. I mean, humankind has never faced a global threat like this since the advent of modern medicine, which really spurred these 70, 100,000 volunteers to sign up for these trials. It takes years sometimes to find even 1,000 people to sign up for a trial. And all of these people, healthy people like you and me, volunteered. That was the second thing that really quickened the process. The third thing was red tape. All the red tape, all the bureaucracy, all the paperwork associated with FDA approvals was cut down. Normally, if we submit to FDA, we get a date that's 12 months out, because they're looking at other things, a million other applications that are before yours. All of that was cut out. This was given priority. So that's why warp speed, that's why quick, but none of the scientific scrutiny was compromised. So I think it's understandable that the trial is having trouble recruiting now, because so many volunteered earlier and now there are approved vaccines. They just want the approved dose. I think that's the problem. Hopefully this won't happen, but sometimes the only way we get people to participate in a trial is if they don't get the vaccine any other way. So sometimes that, unfortunately, is the only way to get people to volunteer for a vaccine trial.
Okay, I'm just reading out one question from the chat box. Do both doses need to be the same, or can one change vaccines in between two doses?
FDA right now in the US recommends same. So if you got Moderna, get Moderna. If you got Pfizer, get Pfizer, because that's how they've been studied. Nobody has really studied mixing of the doses. Now, does that mean that if you got Moderna and then you got Pfizer, something bad will happen? Probably not. They're pretty similar. Will the efficacy still be 94 to 95%? We don't know, right? That's why they're recommending what was studied. That's what we will recommend. UK is facing a huge surge. So they are actually recommending, let's at least give everybody one dose. And then if we run out and we have to give you the second dose a little late, or we have to give you a different vaccine as a second dose, the efficacy will go down a little bit, but that's better than you catching coronavirus right now for your vaccine. Because what use is future 95% protection if you die of coronavirus right now waiting for the vaccine. So that's why the UK is probably going to adopt a different stance, just give everybody at least one dose now. What I did not mention was Pfizer, even after one dose, there was 50% protection. Moderna, after one dose, there was 80% protection. So even that first dose is giving people protection. So that's why the UK is doing something different. But right now in the US, it seems to be you get one, you get the same one second time. We will see what happens with the AstraZeneca and the Biotech vaccine. They both claim it will be 2 doses.
Okay, and
People
I think
say for Indian population, Biotech is better, Indian vaccine. Is it correct? Or just because it's cheaper?
If they have good data. So I'm waiting for their phase 3 trials. I don't think that they will have bad data, but you never know till you know. So if they have good data, then yes, it does not need to be refrigerated. It's probably cheaper. So to give you a rough example, right? Pfizer is charging the US government about $19.50 per dose. Okay. Moderna is charging the US government about $32 per dose. AstraZeneca claims that it will charge the Indian government less than 500 rupees per dose. We have to wait and see what Bharat Biotech is going to charge, right? But typically all these government contracts, they are what are called cost plus contracts. So the government signs a contract saying whatever is your cost of manufacturing, you can add plus $1 or $2. That's all we're going to pay you. So these vaccine manufacturers don't stand to make huge profits. They are doing this more for society and to get their name out there, to get their product out there, to get the trust in them. So we have to wait for the Bharat Biotech data. Now I will clarify, I don't think that Bharat Biotech data will be as good as the mRNA data. The mRNA platform just seems to be very, very robust. But if those vaccines are not available in India, it's meaningless. That efficacy is meaningless to the Indian population. So we have to wait for the Bharat Biotech data. And if it is good, then that and AstraZeneca are both good options.
Okay, I think these have already been answered. A person with autoimmune disease, should a person with autoimmune disease take the vaccine? I think you've already made it very clear that anyone is always better off taking the vaccine rather than missing it. And how about Hashimoto's and the vaccine? Again,
it should be fine. It should be fine. There were no cases of Hashimoto's reported in any of the trials. There were no cases of Guillain-Barré, which is another thing to worry about. None reported. So even the Guillain-Barré Syndrome Foundation is recommending that their patients take the vaccine. Even those who have it should take the vaccine.
And is there any recommended conception gap, as in after taking a vaccine, when can we advise a woman that, okay, now you can plan a conception of a pregnancy?
So there is no real data, right? Because like I said, so a few women conceived during the trial and they seem doing okay. So I would base that decision on the other factors going on in that patient's life. Like what is their age? You know, if this is an IVF patient where every month is crucial, you probably don't want to wait. If this is just a patient that, you know, is just thinking and is saying, well, maybe I can try after 6 months, doesn't really matter, we are still young, then it's a different matter. So I would base that decision of conception on the other factors. The vaccine really should not be any deciding factor in there. I don't think it's going to really harm or help conception in any way.
Okay. And would you advise someone who plans to travel to the US in the next month to go and take the vaccine there?
If you come here and you are able to get a dose, yes, sure, take it. But you're going to have to wait 3 or 4 weeks, take the second dose as well before you won't get that efficacy. It's still touch and go. Every state here is doing something different. Every city here is doing something different. But hopefully in the next few weeks, we will get things sorted out and we will get everything streamlined, and then we will be able to vaccinate anybody that comes and gets the vaccine. I mean, as we're always begging people to take vaccines, right? I don't want to be in a situation where I tell somebody, don't take the vaccine because it's so very effective. So if you're coming and you're going to be here and you, by your age or qualification, qualify in whatever tier is going on at that time, yeah, definitely go for it.
And are there any Chinese vaccines in the market?
So yes, the Chinese vaccine, right? It's also an inactivated vaccine, just like the Biotech vaccine. Again, the data is not available in the public domain. So I don't know. They claim great efficacy. And I think the Middle East is using them right now. I believe UAE, Dubai, they are using the Chinese vaccine. They are vaccinating with Sinopharm, I think is the name. I don't have their data, but it's an inactivated vaccine like the Biotech vaccine. We know those vaccines work. We just don't know how well. And
the results are yet to be.
Yeah. They must have looked at safety data, but I don't have it.
Okay. And is AstraZeneca doing trials for 11 to 15-year-olds, which is the more?
I don't know yet because they have trials in South America and UK, not in the US. So I haven't any data about international trials, whether they have opened it up to 12 to 16, 12 to 18.
And I think the last question, is the vaccine free of cost for the common man in the USA?
Yes, it is. Wow. Nothing technically is free of cost. It's paid by the federal government, so it's paid by taxpayer money. But yes, they are not going to charge anybody out of pocket. They're not going to charge anybody's insurance. The federal government has used taxpayer money to pay for all the vaccines. They are in fact even paying for the needle and the syringe and the mask for the worker who will be giving the vaccine, and the gown and the gloves and everything. So they're trying to make it very, very subsidized. Now, the centers that are giving the vaccine, right, they are allowed to charge a small charge to cover the cost of the staff salary and their overhead and utilities and things like that for keeping their office open. So there is a small charge that they can charge to the patient's insurance to cover that. It's very minimal. And if the patient does not have any insurance here, then the State Department is going to cover the cost for the doctors. But yes, the vaccine out of pocket is free.
Okay, I think we have taken
chimpanzee-based RNA is anywhere. I mean, apart from this vaccine, are there any cases in past that chimpanzee-based RNA were used?
That chimpanzee vector is brand new. They were trying to use that platform for malaria and for HIV, and that has never come to actual fruition, but that's what they were trying it for. So they have never made an actual vaccine with that chimpanzee vector. There are other adenoviral vaccines used, very limited. Ebola and rabies have adenoviral vaccines. The Russian coronavirus vaccine, which they've named Sputnik, uses 2 other different adenoviruses, not this chimpanzee virus. But this one is brand new. The human population has never seen it before.
Okay, thank you. I think from my side, we have covered most of the questions. Thank you, Dr.
Most of
Lukena.
all questions.
Yeah, all the questions. Most of them are actually covered in your talk itself. So I was just taking the ones that were coming in the chat box. Thank you very much for a very lucid and clear presentation for all of us. Thank you.
Yes, definitely. Thank you for giving me the opportunity. It was very nice to meet all of you.
Thanks a lot for this great session today. Thank you, Doctor. May I request Rotarian Kishore to make the secretarial announcement now?
Yeah, thanks, Jahangir. I'm happy to note that more than 100 people have attended this program for the great knowledge, and request all members to attend the next Saturday. We have our club assembly, which will be attended by our district secretary. So request all to attend that. These are the only announcements.
So thank you, Dr. Dole and Dr. Sneha.
Pleasure. Thank you.
Yeah, Sneha, great job.
Great job. Yeah, Sneha, with all your shopping and taking out time.
Not at all. It's a pleasure.
Getting married.
And we forgot to thank mom.
Thank you, Dr. Lukena. Thank you very much. Thank you, Juliana, for organizing.
It was really,
Very much.
very clear.
Juliana is there. Juliana, thank you so much for requesting your daughter to do this honors for us.
It was a great session. Great session.
Excellent. Truly. Very nice. Wonderful session.
Very nice.